not cause ocular surface side effects or epithelial damage to the surface. And the polymer use is probably going to help in the retention of the tears on the ocular surface, and it is optically clear. But then this is an ideal scenario, and I look at it in a little more detail in the subsequent slides as well. So when you look at what are these drops which you're using, are they really mimicking the tears? But then it does get a little more complicated than that, because they're not just lubricating. There is the concept of osmoprotection, which is that common, which I'll just explain to you in the subsequent slide. There are several additives such as this which are going to help on in binding and causing a mucomimetic property and help in the tear retention. And where you want to avoid preservatives in your medication when the patient has a very significant ocular disease, you need frequent applications of medicines because of a coexisting glaucoma, and there are other ocular surface morbidities. You need to look at avoiding preservatives in such patients. And again, add on or enhance your topical lubricant therapy with additive treatments by changing the formation, the topical formulation, and adding on antibiotics or the other mechanisms or environmental supports you need for these patients. So a quick look at what does the the viscoenhancer contain. It has HPMC, CMCs, carbomers, PVA, dextran, PVA, and all these. So all of them don't enhance viscosity. There are some of them which will decrease the viscosity of and you probably in a hypertonic tears, you're going to need something which is going to decrease the tear osmolarity. And the polymers you use follow under these two categories. They are polysaccharides or acrylics, and you have got the newer ones which are now coming to. I'll just skip this, and I just wanted to understand what is the scientific evidence in choosing the right comfort agent for you. So I did look at this fantastic paper which does for wonderful reading, and of course their polymath derivations were a little too complex for me to understand. But when I looked at what is the comfort index of all the comfort common agents which you looked at, I was quite surprised to find your HPMC still rules higher than CMC as a comfort index agent. So that really answered my question when I always used to wonder my patients containing HPMC formulations do better than those with hyaluronic acids. So what you need to think is, where will I choose my aqueous base? What is the viscoenhancer which I need for this patient, and what is the additive I need to use on for these patients? These are the various mechanisms by which it is really going to enhance my the patient therapy in terms of increasing the tear film, prevents the ocular surface desiccation, increases the retention of the tear. So is my tear working in all these patients is what is required. But due to lack of time, I'll just go into the diagrammatic representation. This is what a normal ocular surface looks like. And when the tear film gets disrupted, it is going to result in hypertonicity of the tears, and these will cause dryness and desiccation of the tears. When you just give a wetting agent, it perhaps helps to restore. But then when these cells have gone to the next level of hypertonic tear-induced damage, it's not just enough when you just give a wetting agent. So you need to add on additives on these agents, which are probably going to restore or prevent the occurrence of apoptosis in these patients, and that will help a longer give you longer comforts for these patients in treatments. So such additives are known as compatible solutes, which are present in your formulations, and depending on assessing the ocular surface evaluation parameters, you'll need to add on whether the lubricant you're prescribing contains these additives. I did go back and look at, are there any particular prescribing guidelines? So this is probably way back in 2013, but this is the only guideline which I did find out, which I could pick on, which is available for recommendations, where you would use first line, second line, and third line therapies. But with the new DUCE recommendations, I think we are now moving on to using this new molecule which is there on the block even for as a first line therapy for most of our medicine, in terms that the hyaluronic acid is a naturally occurring biopolymer, and its hyaluronate ligand binds well with the increased CD44 expression on the ocular surface, and thereby helps reduce the ocular surface damage in these patients before it's going to start occur when a dry eye decrease. So this is what is the molecular level in which probably hyaluronic acid is acting. So to summarize, you not only treat the patient in symptoms, you understand if the meibomian gland is also affected, and you're going to add on drugs which are going to give or take care of the lipid layers, and that's when you look at the tear lipid contents as well, and you add on other additive treatments which are going to take care for the tear production loss as well. So the question of decision depends upon, does it just contain the aqueous base? Do you need to give the right kind of viscoelasticity enhancer depending upon the osmolarity of the tears of the patient you're dealing with, and the right additives as well? Thank you.
Thank you, Professor Vanathi. I think she has very nicely highlighted the different features of the different polymers that are there. And she's also indicated to us at least pharmacologically, the superiority or the difference between one type of polymer and the other. And we'll discuss this in greater detail when we look at the clinical aspects in the panel discussion, where we try and look at mild, moderate, and severe disease, that with Meibomian Gland Dysfunction, that with inflammatory components, and then see how we can modify our approach. I'm going to request Dr. Rohit Shetty to give us his presentation. Rohit has to leave a little earlier for another session, and so he's going to be telling us about the inflammation connection with dry eye disease. So this is some of the newer aspects in this. Ready with the?
I'm ready. It's coming here, but it's not here.
Thank
you, sir. And these are my financial interests of this. When few years back, when we started working on vitamin D as one of its, as a role in dry eye, one of the quick question which was asked to us is this: 70% of Indians are deficient. How does it matter? That means that it doesn't really matter because you're just picking up one more factor in a patient with dry eye. It should not actually be a reason. However, this is what is been published, and we know it's increasing. This is an old report of 2014. By now it will be 100% or 99% of us are deficient. Then we started looking at what happens in a person who develops any disease, whether it's cancer or anything in your body. There are a few things which is important. If you look at a model, you have to have a disease specific factors, you have to have a genetic factors, and your host response. If you have one of these two, you just get a subclinical one. For example, these two things, you get a subclinical one. You person should have all the three in equal amounts to get a disease, and then that becomes clinical. Then of course, multiple other factors play in, your whole molecular signatures, the place where you live, what you eat, and the environment, how good or conducive it is to develop into a disease. This is what made us thinking. This was a paper in 2014 about how vitamin D cells are being secreted, or these markers out here tell us that the VDR, the vitamin D receptors, are present in your corneal epithelial cells. One thing we know, that God doesn't put anything without any reason. If he has to put there, that means it has to work something, it has to do something. So that's what started us thinking. Why is it there, and what does it do? Incidentally, a lot of other people were also trying to figure out in the same way, but it's like the 6 blind men and the elephant, each one trying to work on one arm of it. Some people were